Welcome to Health Law Pulse, the podcast where healthcare and law meet in real conversations with the leaders shaping our system. I'm your host, Jonathan Rhodes, a healthcare attorney and founder of Health Law Counsel, LLC. For today's episode, we're focusing on something that sits at the core of healthcare quality and patient safety, how we train, credential, and support physicians throughout their careers. I'm honored to be joined by Dr. Michael Rhodes. Dr. Rhodes is the Associate Dean of Clinical Affairs at the Noorda College of Osteopathic Medicine in Provo, Utah. Before joining Noorda, Dr. Rhodes spent more than 25 years at Intermountain Health, where he served in a number of leadership roles, including Medical Director for Quality and Credentialing across multiple hospitals and Program Director of the Utah Valley Family Medicine Residency for 15 years. Over the course of his career, Dr. Rhodes has trained hundreds of resident physicians and medical students, helped shape credentialing and peer review processes, and worked at the intersection of clinical care, education, and quality improvement, all while continuing to practice full-spectrum family medicine. In today's conversation, we'll explore what it takes to build a new medical school, how credentialing and quality oversight really work inside hospitals, and what medical education needs to prepare physicians for the realities of modern healthcare. Dr. Rhodes, welcome to Health Law Pulse. I'm grateful that you're here on the inaugural episode. Thanks for taking some time to chat with me. I figured I would start this podcast with the person who I've known my whole life and who's known me for the longest. So thank you for being here. And in full disclosure to everyone, Michael is my older brother. Many people refer to me as the younger and better looking version
all the
of
time.
Mike.
Yeah, that was all the time.
No, I don't think that. And I've never said that. I've just heard other people say it. So just wanted to throw that out there. But in all seriousness, Mike is one of the smartest, brilliant, and kindest people I know. So I appreciate you being here, and I appreciate you imparting some of your insight on the topics we're going to be covering today.
Well, yeah, thanks for having me, John. And I used to always tell everybody that my younger brother, he went to the dark side of law, so it's okay. Should come back to, but it's okay. Yeah, so he's a good lawyer. He's on healthcare.
I appreciate that. I tend to blame healthcare and my career on my hair. I mean that's, but you have sort of debunked that. So you're in healthcare. You have a full head of hair.
Genetics.
Apparently,
we're still fighting DNA. We all fight DNA.
Well, perfect. Well, yeah, thanks for being here. Let's go ahead and get started. So Mike, before we get too deep in the conversation, I'd love to hear a little bit about what originally drew you to medicine. You did your undergrad at University of Georgia, went to Medical School of Georgia, and did your residency there in Georgia as well, and then later on moved to Utah. But what originally drew you to medicine?
You know, it was kind of an accident. Everybody has these stories about, I've always wanted to be a doctor since I was 4 or 5. And that wasn't my path. I guess people have different paths. I was more likely to be an engineer or an architect. Our uncle Arvid was an architect and had his own firm down in Phoenix, Arizona area and stuff at the time. When as a young child, I always remember building things between Lincoln Logs, Legos, erector sets. That was all my thing. Could always find me somewhere with cardboard construction tape back before we had internet and Wi-Fi. So it was always, you were just out building.
We hardly remember that. Yeah.
So, and then through high school, I loved drafting, drawing, just the whole idea of conceptualizing things and drawing, and just thought that's what I was going to do. Actually, when I started college in Georgia, I was actually working as a draftsman for a civil engineer, putting myself through school, and then found myself at one of those moments in life when you go, oh no, what have I done? Because I cannot sit at a desk and draw 8 hours a day. That's when I probably, in retrospect now, I can say I had undiagnosed and untreated ADD. And I was like, there is no way I could sit here. I will go freaking insane. And I could do it for an hour or two in a classroom, but I could not do it for 8 hours a day when during the summers or when I had time to work and things like that. So that's when I started looking at other career paths. I excelled, was doing really well in my science classes. Received the freshman chemistry award for my general chemistry stuff, and just kind of, I'll just go into something there. I always enjoy. I do remember even back, even junior high, science teachers impressing me, and just they were really good teachers. I was enthralled by it. At our Lehigh High here, I remember trying to sign up for a physics class, and they came to me and said, "Well, we don't have one." And I go, "Well, I want to take physics." And they go, "Well, we'll find someone to give
That was
you."
before they invented physics, Mike. We all know
Exactly. So,
that.
so I was like, okay. And so, well, I guess I really have always liked the sciences and natural sciences. So that's kind of what brought me that way. And then, but you never think you're smart enough to. I never, thought I was smart enough to be a doctor. Those are smart people, and I'm still not smart, but
No.
I'm also kind of, don't give up kind of thing. So yeah, draw. Then I was going to do. I thought I'll do. I went into biochemistry as my undergrad major. Was going to do food science and
Hmm.
invent the next best Cheetos or something like that.
There's still
And
time. There's still time.
yeah, exactly. But I really, once you learn a lot of things. I always thought I loved teaching as a as a kid and kind of growing up. I loved being able to talk to other people about concepts like that, conceptual science, health topics, and things like that draw me into medicine just as a way. I know it sounds like a cliche, but it is kind of a way to be able to give back to your fellow human beings and try to really help others. And if I learn all these things, then how do I turn around and make the world a better place for me having been here? So just, I don't want to say on a whim, but just kind of on a dare to myself, do I even dare apply to med school? Lo and behold, I actually got in. How about that?
The rest is history.
The rest is history. Yeah. So yeah, I've enjoyed it. I've loved it. Been a great career.
Excellent. Well, I'd love to start with a little bit about what you're doing now, and then we can maybe back up. I'd love to hear your thoughts a little bit later in terms of how you feel primary care, family care has evolved since you began your career, which was, when did you start your residency?
So residency in 91.
91. Okay. So 30 plus years. I'm sure you've seen a lot of changes in this space. And so I'd love to get your thoughts on that. But in terms of your current work, you're currently at Noorda College of Osteopathic Medicine. Can you just tell us a little bit about what about Noorda, about what you're doing there, and a little bit about what drew you to that opportunity to create this new medical school, which has only been around for a few years?
Absolutely. Yeah. Noorda College of Osteopathic Medicine is a relatively new medical school in Provo, Utah. We have had our first graduating class. So we have one graduating class, and our next class will be coming up here. Their matches, they call it the matches in March, and we'll have that up going. I've been with the school for a little over 7+ years. I was employee number 3.
Hmm.
And what drew me to that, for folks that may either from this area or know that, a medical school, at least in our county, that's Utah County, is home to Brigham Young University that people may have heard of. It's also home to an even larger school called Utah Valley University.
Mm-hmm.
And when you total up all of the undergrads in the state of Utah, and I'm talking students who graduate from Utah-based 4-year degrees that get accepted into medical school and leave the state, it's over 700 kids a year.
Wow.
So the state creates a large number of these kids that then wind up, as I did, and leaving the state as I did to go to University of Georgia, Medical College of Georgia. But they leave the state, and then you spend your career, either trying to come back or find a position and work out something that if you want to come back to the area. So it's always been seen as kind of a brain drain. We train these great minds, at least in undergrad, then we send them off to become doctors in another state. So a med school in our area has been talked about for quite a long time. The University of Utah for a century has been had been the only medical school really in the state. And they've gone through ups and downs. There was even a period of time that wasn't that long ago, at least in my memory, where they even decreased the size of their med school, for lack of funding and some other reasons. So it's always kind of been a ebbed and flowed. But we've always had a lot of medical students that came back to the area to try to do their training. And I had previously, before I joined Noorda, had been a residency director, and I can get back to that in a minute, what that means, locally here at a family medicine program. I did that for 17 years. But when this this position opened up for me, I was actually acting as an associate chief medical officer with Intermountain Healthcare in this region, and overseeing kind of credentialing and things like that and safety at several area hospitals. And they had a founding dean that came and had spoken to us about this opportunity to create a med school. Now, that had been discussed before. So in all fairness, the med school in the area has been discussed before and honestly shot down. And the reason a lot of the medical professionals, including myself at the time, honestly even shot it down, is that these were schools that had other campuses, other places that were just going to take what was working in their state and copy and paste that and put it in Provo, Utah.
Sure.
And Provo is a different breed of folks. We're a little weird, maybe not as weird as Austin, Texas. But no, it's a little different people. And we thought, but when this concept came up, it was like, no, so Noorda was going to be homegrown. It was going to be a de novo from the ground up med school. It wasn't going to be a satellite campus of another existing college.
Right.
This was the opportunity to create something new. And so I thought this could work. We need this here, but it needs to work here in this environment. It needs to work with our hospital systems, our physicians, our patient population, and we need to be able to formulate this. So it was, that's when the creative juices start flowing and say, if I could go back and redesign all my years of medical education and correct all the woes that were inflicted upon me, how could I do that better?
So I love how you mentioned that. And this past summer, you gave me a tour of the school, which I left very, very much amazed at how much technology is utilized in medical education. I'm assuming that's where you had your creative juices flowing and you thought, man, if we just, a lot of this technology probably didn't exist when you went to medical school, but then now you have the opportunity to, it's not an old joke. It's not an old joke.
Oh, come on.
But you have an opportunity to utilize.
When I served with Stonewall Jackson.
Not an old joke. But you have the opportunity to utilize a lot of innovation and technology that just didn't exist anywhere back in the 90s. And so tell me a little bit about what does innovation look like in medical education today? And where is that field headed? Where compared to when you went to school versus where we are now, what does that look like? And where is that taking us into the future?
And it's multifaceted. So yes, and I'll speak on technology. That's one piece of it for sure. And another piece is devising a different way to deliver the content so the modern day student can consume it in a way that this generation of students consumes educational content. Yes, I'm older. So yes, I started school with, overhead transparencies and a grease pencil. Mm-hmm. My organic chemistry professor just going at the speed of sound and you're trying to copy it too. I advanced to 35 millimeter slide carousels where, 25% of the slides were either upside down or backwards, so it's just like, so that was all before the days of PowerPoint. So technology has evolved. So tech is one piece. And I got to be a piece of this. My vision for technology goes into a lot. What you even saw there is what we do with our simulation.
Right.
I can jump right in that. Sim is a lot of it. Is simulating that medical encounter that you can't otherwise do, or someone doesn't get sometimes until their third year of residency or fourth year, or until they're 5 years into practice when they have this patient that has all these characteristics coming together, the perfect storm. You can train physicians, can read a textbook, and they can go through a case scenario. They can stand up until you have done it. And been through that. It's tough to develop that into what in the military we call muscle memory, right? So you just to react. So, and that came out of even a lot of the patient safety stuff I was doing with Intermountain at the time. A lot of patient safety initiatives within healthcare, we honestly stole from aviation. And that's a whole different historical, probably a whole podcast on where all that came out of aviation and how modern medicine is stealing a lot of patient initiative, even from the checklist that we use in the ORs.
Okay.
So from a checklist to a timeout that we use in our operating rooms, a lot of this we stole out of the aviation industry. And
interesting.
And Airline pilots and aviation have been using simulators since World War One
Wow.
to
Yeah.
train their pilots not to die
Right.
and how not to die. And then military training our in the military, you can listen to different folks on that because again, I'm a novice, just love of military history, and it's you always would fight the way you trained. So
Right.
and you want to train the way you fight. So I was like, can we take those things and put those into medicine and
Yeah.
train doctors that in their worst kind of environment, train them to default to their muscle memory so they don't have to be thinking about all of the things at that time. They just react the right way, the way that they were trained. And so simulation based healthcare or medical education has been born. And as you mentioned, we have a fairly robust simulation suite that involves outpatient clinic to simulate a clinic, regular routine clinic environment.
Mm-hmm.
Students go in there and they meet, we call them standardized patients or SPs. These are basically community actors that are come in and they are compensated and they're given the role. Today, you're going to be a 42-year-old diabetic with a cough for 3 weeks. And they can be simple complaints, but then they get more and more complex as the students progress. From the clinic setting, we have an ER, emergency room. We have an OR, a trauma bay. We have a delivery room. We have 4 or 5 just general inpatient hospital beds. So as students progress through the curriculum, then they can go into different types of high-risk simulations as a team. And that was another my big thing. A big thing of mine was we all seemed, I remember training in med school, this is the way you're going to do it. And I'd like to liken this to my first code, the first code blue that you ever run in the
Right.
hospital. Well, I trained it to do this way, and then you have your registered nurse over here. Well, they trained to do it this way. And the respiratory therapist trained to do it this way. Your anesthesiologist did this way. And then you all look at each other and I thought we were all on the same team, but we didn't train. We trained in silos. We didn't really train together that much of a team.
Well, to that point, so you have an allied health
We
professional
do.
school
Yeah,
across the street, and you do a lot with them, right? To sort of,
they aren't
I think,
ours. They're
different school, right?
board and all that kind of stuff. But yeah, we partner with them. In fact, I had one of them writing me today to come in and do. These are called IP events, interprofessional activity events, where we train together. Our PA students. We even had EMS from one of the emergency medical EMS schools, Guardian here locally come in, ambulance crews and things like that and stuff as well, and train kind of together in teams. Because medicine, I tell all my students all the time, medicine's a team sport.
Right.
You will never ever practice in a silo, even if you go to rural, wherever, Oklahoma, you're going to have team members either in your office or you're going to have to pick up the phone. You're going to have to call someone, your specialist at the hospital. Medicine is a team sport.
Right.
And you have to be able to, know and work how together on a team. So anyway,
Yeah.
I don't want to ramble too much, but yeah, it brought a lot of that simulation and teamwork into our whole sim environment. And the technology is just a way to help us do that simulation.
Yeah.
More realistic based technology now is a lot more a realistic based simulation than it was decades ago.
Right.
We have mannequins that, cost $250,000. And, their eyes will follow you around the room and will respond to you, and they have pulses. And you can do chest compressions on them. You can start, lines on them. You can defibrillate them. You can do all kinds of things and stuff to them.
So Michael, what's really striking as I'm here listening to you talk about building Noorda is just how intentional medical education has to be, right? And you mentioned even now students consume knowledge differently than they did maybe 20, 30, 40 years ago. So it has to be very intentional. And it's not just about knowledge, it's about preparing physicians for the system they're actually going to practice in. So there's obviously the theory and the knowledge, but there's also the practical aspect of doing something over and over and over again, so that when you do it in real life, you're out in your actual practice, then you're prepared for it. And it sort of brings me to the next area I wanted to explore with you, because the downstream impact of medical education shows up more clearly, I think, in primary care and family medicine. You've spent decades practicing full spectrum family medicine while also training residents and also training medical students. You've seen the field evolve clinically, financially, culturally, politically, and you've watched how those changes affect both physician career choices and patient access. So I kind of want to shift a little bit from how we train physicians to what they're walking into once that training ends, particularly in primary care. And please push back if you disagree, but it feels like family medicine has changed dramatically over your career. In your view, what shifts have been most impactful, or what's the first thing that comes to mind?
I know the first thing, what we talked about, you're absolutely right. Primary care, obviously I'm a family doctor. So I'm going to say that's where it's at,
Yeah,
but it's also frontline, medical delivery of modern medical care.
right,
And you have to be able to work again, be a team member or work within that team, but you're often the individual who that patient or that individual is going to come to first. And I was drawn to primary care because it's also about developing relationships with people.
sure.
I love problem solving. So I love it when I have to think through a problem, a
Mhm.
Gedanken experiment or a thought experiment, and have to think through an issue and do it in the most efficient and cost effective manner and all those things. And that's great to be able to figure out how I can help somebody so we can figure out what's wrong so we can figure out how to help you. But the bottom of that is you can't do that without relationships.
Right.
And so, and this is where the modern physicians can get themselves into trouble because they think they just have to learn a bunch of facts
Mm.
and figures. I can memorize the Krebs cycle. This is just a biometabolism, thing. It's
Right.
something how you metabolize things in your liver. Well, I can tell you your patient doesn't care about that. They just want to know, is that drug going to kill me? If you go back to our simulations, our first two simulations that we do with our students is just to have them sit down, make eye contact with the patient, introduce
Hmm.
themselves, and can you talk to them and not be weird?
Wow, that's interesting.
Because
Yeah.
I mean, I tell the kids during orientation week, I said, you're here at school. This is what's going to go on. But you were all nerds in school. We all were. Okay. You were science nerds. That's why we're here. But now
Yeah.
we have to
Yeah.
learn we have to teach you how to talk to other human beings and take this science stuff and explain it to the patient that's
Yeah.
there in front of you. So their first several, two or three simulations are just about how to talk a patient, how to get that history, how to communicate, how to evoke that empathy. Or did you stand at the door with your hand on the doorknob the whole time? Were you on the
Sure.
keyboard the whole time with your back toward to them? Did you never even introduce yourselves? And we film and record those. But primary care always attracted me from the beginning. This time I got accepted to med school, I was immediately attracted to family medicine.
Mm.
Um, and you get all those things through med school. Oh, you shouldn't do that. You should do something else. You're not going to make any money. You'll never be able to pay off your student loans. All of that's false. I hear all the rumors. I heard 35 years ago that family medicine was a dying breed. It's going to be replaced by PAs and mid levels, or
Let
and
me cross
no,
off
and they
those
don't go into
questions from my
primary care
checklist.
because all the PAs, they can make more money working for the vascular surgeons and the thoracic surgeons. They don't make money in
Yeah.
primary care either, so they don't do that either. So the realities have kind of sunk in with that. So yeah, I was always drawn to it because I liked also the breadth of it.
Yeah.
Again, that probably
Yeah.
maybe goes back to my ADD. And when you get into a primary care clinic, I always thought it was like the old game show, What's Behind Door Number Three? It's like I never knew what I was going to get.
Like, let's make a deal,
Yeah,
right?
let's make a
Yeah.
deal. Exactly.
Are you
I could
comparing family care to let's make a deal? That's great.
absolutely. I mean, I would go my door number one. I have my little 83-year-old, who's having trouble getting around at
Yeah.
home, and
You
we're
just don't know what
working
to
through.
expect.
Yeah, we're working through
Yeah.
medications. I go from there to the next room with the new mom who's dealing with new mommy syndrome. And she's got a 12-month-old that's crying and won't feed right and doing all
Right.
these other kind of things and stuff. And you're trying to help people through life. Uh,
Yeah.
and it's like, then I go from that door to the next door, who's the teenager who's got a sports physical or something else coming up, but they
Yeah.
have got concerns about their sports induced asthma or whatever they have to do. So it's just, I
Well,
love the variety that I got.
well, and I love that you mentioned that, and I think about all the primary care practices I've worked with, and it does seem like it's a common theme that relationships are critical. Like developing that relationship with the patient is just as important as providing quality care, right? If not more so. And so, um,
I mean, doctors, we ask and expect some pretty socially invasive questions about
yeah,
people,
yeah,
Um, and
they
how
got to be able to trust you.
they
You
have
got
to
to
be able
earn
to
that
trust you. And
trust.
how do you do that if you don't have a relationship with somebody? Nobody walks in and sees a doctor for the first time and says, "Doc, I'm depressed. I've been
Right.
having suicidal thoughts for the past 3 weeks, and
Right.
my wife left me, and the
Yeah.
kids that my dog died, and I'm going to get fired." And people
Yeah.
won't do that. They have to have had a relationship with you for months or years and stuff about something that they built that trust before they'll open up and share with you. And so I always got these days we're kind of asked to we're forced to ask some of these questions sometimes called PHQ-9 on you get that little
Hmm.
questionnaire at your doctor's
Yeah.
office.
Yeah.
Have
Yeah.
you been
Yeah.
any mood swings this week and
All
things
right.
like that. I think people are really going to fill that out accurately,
Yeah.
you know,
Yeah. No, it's
unless
fair. I mean,
they
you
trust
got
the
to have that
person who's
trust.
going to read that. So
Yeah. So let me kind of bringing that and intersecting it with your comments about team and how important that is. And we've all got to be aligned on how we're going to properly care for this patient based on his or her conditions and comorbidities and all of that. And it kind of makes me think of managed care, specifically value-based care. Have you seen um the move towards value-based care impact family physicians on the ground? Has that changed it at all? Has that impacted family physicians at all?
it's changing the financial remuneration,
Sure.
right? Quite a bit. There's that other good read, have you ever had that read, Who Moved My Cheese?
Mhm.
Too, it's like, and so these targets kind of move around a lot.
Right.
Um, about can we compensate physicians in a better way? And that motivates some people. But at the end of the day, I don't think that motivates most primary care docs. Again, they want
Okay.
the relationship and they just want to help
Yeah.
their patient get better. Because if I have to check 6 boxes on 3 different screens inside my EMR to make that
Right.
happen, so I get a
Yeah.
little tick mark bonus of the year. Trust me, they don't really
They
care
don't-
about that.
Well, that's good. That's good to hear. And so, I mean, you mentioned something about, um, you really haven't seen a change. And correct me if I misheard you, but in terms of students going into primary care, are you seeing less of that? What trends are
No,
you seeing? Are they where is it going?
it's still on the rise. It is,
Okay.
and there was a dip, I would say maybe late 90s, early 2000s. If you looked across, if you can go onto nrmp.org. That's
Okay.
the National Residency Match Program, and they keep data analysis back for decades where all the allopathic and osteopathic med students graduate and what specialties they go into. So we can follow these trends back for
Sure.
decades, for sure. And you can see differences at different kinds of medical schools. There are the big, larger research type institutions that turn out left eyebrow only surgeons, or
Yeah.
you know what I mean, very, very,
Is that a new
very
specialty?
subspecialized type people.
Sure, sure.
Um, and those that tend to turn out a lot more primary care,
Yeah.
and I am an allopathic. I am an MD, trained at an MD school, but yes, I'm practicing and working and an associate dean of clinical medicine at an osteopathic med school.
Right.
Um, and it's a philosophy of care that has to do more with about whole body and person. That this isn't it's not a disease that happens to be a person in front of me. This is a person that
Right.
also happens to have these ailments and these problems. So it's just a philosophy of care. And if you looked across that spectrum, osteopathic medicine tends to attract or graduate a lot more primary care docs,
Okay.
just because of that. I think that basic philosophy of care, how they
Mhm.
care for folks, than the larger allopathic research type institutions. We need those people. We need all kinds. We need them all.
Right. Right.
So that's the truth. But yeah, it's
Excellent.
definitely on the rise. We're creating more and more residency programs and even more primary care residency programs. The last 3 of the 4 that were created in our state were all primary care residency training programs.
It's great.
And we need even more. So.
That's great to hear. Because you do hear commonly, I know there are healthcare deserts, there are physician shortages and APP shortages out there, but it's great to hear that there are a lot of students who are still interested in primary care and want to enter into that field.
I think they are. They come in that way. We get them. I think the mentoring, we have a lot of our faculty that I see are primary care based,
Okay.
kind of faculty. So it's mentoring. And I'll tell my students straight out, I want you to be whatever it is you want to be when you grow up.
Yeah.
You're going to be better at it. If you want
Yeah.
to be a cardiologist, that's great. You're going to be better at it. I don't expect you to, to everybody want to be a family doc. We need them all. But I think a lot of it does have to do with mentoring and things that students want to be what they can even imagine themselves. And if they don't, if they go to a college, well, I got accepted to 2 med schools in the state of Georgia, one in Atlanta, a big city,
Mhm.
well known, starts with an E. It's a prestigious, they used to call themselves the Harvard of the South, and I got accepted to the state school in Augusta, Georgia, MCG at the time. But the one in Atlanta didn't even have a Department of Family Medicine at the
Mm.
time. And they do now, but,
Yeah.
it's come the way, but they didn't at the time. So it's this whole kind of, you know, dichotomy set up where you're only going to be what you can even imagine yourself we could be. If you go to a school or you surround you
Right.
by and no one does that, no one's even heard of doing that, and they all think that's weird, you're not going to want to be that when you
Right.
grow
Yeah. No, that makes sense. That makes sense. Well, great, Mike. Hey, just want to shift gears real quick to quality, right? And how that interplays. And you have a ton of experience in this. So, from a regulatory governance standpoint, I think a lot of the challenges facing primary care today are, at least on paper, are being addressed through quality standards, credentialing requirements, which you're very familiar with, oversight mechanisms. But those tools, as you know, only work if they're applied thoughtfully and fairly. And you've had an extensive experience overseeing quality and credentialing across multiple hospitals. I just want to shift this conversation to how those systems actually function in practice. So when we talk about quality in the modern health system, what do you think? What does that actually mean, or what's the first thing that comes to mind when you think of quality within that frame of reference?
I will always I will think of 2 things, safety
Okay.
and value.
Sure.
So, say you can't have quality if you're hurting people or hurting
Yeah.
things or making mistakes. So that becomes a lot of outcomes based type things.
Right.
Are we practicing safe medicine? And it goes back, what, 1600 years to above all do no harm, or,
Sure.
Hippocrates is, or for your Latin guy, primum non nocere. But that drives me crazy why we use Latin to quote a Greek physician, but don't get me started on that.
Well, there's the nerd coming out of you.
Yeah, and
Yeah,
my nerd coming
appreciate that.
up. But it's still good. We have tools at our disposal that could do a lot of harm. So above all, do no harm. So if we can now hurt people and we can start doing some good, then we get some quality outcomes,
Yep,
quality based stuff. Then you have to balance that with, I'm sorry, but cost comes in. So
sure.
you can create a lot of great outcomes by spending a lot of money. Okay.
Yep.
And I don't want to pick on radiology, but they're easy. Okay. But let's just take something like an MRI. Okay.
Okay.
Okay. Everybody comes to you with a headache does not need an MRI.
Hmm.
Okay. I could sit down and talk to you in about 10 minutes and find out what kind of headache you have, probably what triggers it, what we can start to do to avoid it, between dietary factors, sleep habits, you name it, all kinds of things without even introducing medication. And yes, I've even told people, go see your chiropractor, get some manipulation. You might,
Hmm.
this could be musculoskeletal induced, you
Sure.
might have some issue here that needs something. So I know I'm weird with those weird, MDs. You don't want me doing it, but
Yeah.
some people do need it. But it depends on what the etiology or the cause of that, what's the trigger for that headache. But
Right.
some people do need an MRI. But
Yeah.
what happens in quality is some people will say, oh, quality is everybody gets an MRI for your headache, because we find that 1 out of 1,115 people who actually had a congenital aneurysm, and we
Yeah.
found that before it burst. Okay. Well, let's rank that up. What's an MRI cost? How long does it take to
Right.
get? Um, and then there's even the harm aspect of that on the
Mm.
backside.
Okay.
People think MRI is not harmful. Well, I could show you a lot of screenshots. You could Google MRI accidents right now
Hmm.
and look at people that are hurt by wheelchairs and metal that was in their bodies or things like that,
Right.
because it wasn't done safely.
Right.
So we wind up doing things to people sometimes that aren't safe. We used to think I can switch to my own primary. Well, switch back to primary care and go. We used to screen every male over the age of 50 for prostate cancer
Hmm.
um, by doing PSAs. That's a prostate specific antigen. It's a blood test, and a DRA, digital rectal exam, to try to find those lumps and bumps. All right. Well, that was supposed to be the standard of care, right? Well, how many men in their 50s, as we age, and 60s, their PSA just gradually rises. So we wound up doing biopsies, and thousands of biopsies, and even on folks that had normal, just benign prostatic hypertrophy or enlargement, or BPH.
Hmm.
And so, now recommendations have said quality is backed off of that. Now quality says, well, wait a minute. We're way over. We're sending a lot of normal people, okay, to get some invasive thing done to them.
All right.
If it's just a normal part of aging that isn't cancer and isn't going to kill them, so
Right.
what are we doing? So it's always this balance between, there's outcomes. And so that's why you have to look at the outcomes. Did they get cancer and die of it? Did they get
Right.
cancer and not die of it? Did that aneurysm rupture and have problems? So everything has an outcome and then a cost to detecting it and treating or management along the way. So those are always in the equation of quality when I can get that. So
Right. Okay. That's great. So with quality comes credentialing, and you've been through the credentialing process with many physicians over the years. What are in your experience, the biggest misconceptions that clinicians have about the credentialing process?
that clinicians have?
Yeah. Yeah.
Yeah, most clinicians don't even really have a clue. I would say your average doc doesn't even really know what it means or what is going on in that credentialing office, unless they become a
Interesting.
chairman of a department and they've had to look at those packets of their colleagues.
Hmm.
They probably don't have a clue. At least I had no idea. Maybe I was,
Oh,
dumb and naive.
interesting.
Well, don't answer that one, but coming up through the ranks. But until you're in a place within your department or your specialty where you have peer review responsibility to oversee the quote unquote quality of others,
Right.
credentialing takes on
Sure.
a whole new framework and stuff like that. So,
Well, I
but I
mean,
think
obviously,
most docs are still kind of blind to it.
yeah,
They know what goes on, but they may
kind
not
of in the
really
background.
know what it entails or why
Right.
it's important. So,
So that's really interesting, I'm obviously not asking you to divulge any privileged information here, but what are, like, in your experience,
names have been changed to protect the guilty.
you see so many credentialing applications, you've been through this process. What are some of the most common red flags that tend to worry you during some of these applications that you've reviewed, or this process that you've gone through?
um, Hospital hopping
Oh, okay.
is when docs have gone from one location to another, to another, to
Right.
another, with multiple states across the country. When I see that on their CV in the background, you always want to go, huh,
Oh,
what are they,
interesting.
what are they running from? you know.
Yep.
And so, I mean, you can glance at that and look. It's a pretty quickly. I don't say it's a red flag. It's not red. It may be a yellow. That it
Something to
maybe need
note.
to do a
Sure.
deeper dive. And so now I'm going to look into it and say, were there any issues? Did he have complaints? Quality complaints? Is there anything on the National Practitioner Data Bank, the NPDB, that got reported to the
Right.
system that we need to look into? Did Medicare flag him? And there's a
Right.
different database you can look at and see if there was any Medicare fraud and things like that and stuff. There, why people. But when docs go from every 18 months, 2 years, they're going from one place to another. Life sometimes things catch up to them and they're moving around for a reason. So
That's great. Very important information. Mike, one last question. What's You may have answered this with your comments regarding just the what you enjoy about having a career in primary care and family care, and the breadth of the issues that you work on. But what's really kind of sustained you over the years? What's kept you in this career? What's given you the desire to not only practice it personally, but also to really be interested and have a vested interest in passing that love for primary care and that knowledge on to other generations?
Um, yeah, it's very personal.
Sure.
I do love helping people. I've had relationships with patients for 17, 20 years sometimes. But what would quote unquote, I'd reframe this in my way is what gets me out of bed in the morning,
Yeah.
kind of thing, is medical education. It is teaching.
Yep.
I love the young learner. I love that resident physician or that medical student that's just dipping their toe into this new career and this profession, I should say, of learning that and trying to be a mentor, how to say you can learn all this to help people and not be an a-hole.
Yeah.
Don't be the jerk doctor,
Right.
you
Right.
know. You don't have to bleep that out because I did it for you. Yeah. But and there's a book on
Appreciate
that.
that.
There's a good book in my office on the no a-hole rule, and it's a good read. But yeah, I don't know, I've loved being able to teach and mentor the young students and the residents and stuff through that journey. So, and it's been great.
Love it. Love it. And that's obviously something that a lot of other people have gotten value from your desire and love to be in this field. So, well, Dr. Rhodes, Michael, thank you for a great conversation, sharing your insight on medical education. We talked about primary care, behind the scenes work that you do and your experience in keeping patients safe. I truly do appreciate your time, your expertise, your great insight on these topics on the inaugural episode of Health Law Pulse. And want to thank our listeners for tuning in to Health Law Pulse. If you enjoyed the episode, please subscribe and share it with a colleague. We are on our YouTube channel at Health Law Pulse Podcast or on Spotify and Apple Podcasts. You can also find these links to these episodes on my website at www.healthlawcouncil.com. And if you so desire, you can contact the show if you would like at healthlawpulsepodcast@gmail.com. We'll be back in 2 weeks with more conversations about the intersection of healthcare, law, technology, and leadership. Thank you very much and take care. Thank you for joining us today on the Health Law Pulse. This podcast has been brought to you by Health Law Council, LLC, a healthcare law firm you can rely on. For more information about the services offered by Health Law Council, LLC, visit www.healthlawcouncil.com, or you can email me at john@healthlawcouncil.com.